Yo! Look at this. I got my boy, Dr. Jimmy Choi here.
What's up?
Yeah, so it's Z-Dog MD, a.k.a. Dr. Zubinamanya, and Jimmy Choi, emergency physician. Don't call it an ER, because the ER is like a room, right? You're talking about like emergency department.
Emergency department. Yeah.
Department.
Yeah, it's not a single room.
It's a medicine. It's a whole specialty.
You got it.
Yes. And guys, I hooked up with Jimmy. Jimmy was my student back in the day.
I was prepping for the MCAT, and this guy taught me everything I know, but not everything he knows.
And then he failed the MCAT because I taught him everything I know, which was very...
I did take it twice, just FYI.
So my teaching may or may not be actually useful. But yeah, no, so Jimmy, we haven't seen each other in 25 years.
Something like that, yeah. You had hair.
I had hair, which tells you something, because medical school, residency, beat that ish out of me. Stat. So anyway, so Jimmy's been watching our show because, we're that cool. And he said, I've noticed you've been talking a lot about healthcare worker violence, occupational violence, Silent No More is a hashtag, all the horrible things that have been going on, including recently, nurse got stabbed, guy got parole, phlebotomist got stabbed by someone, the nurse in Massachusetts who had all the wounds. I don't know if you saw her.
I saw that, yeah.
Oh, it was just horrible, and all our thoughts go out to them. And we've been talking about it and sharing it. And I said, well, but what can we do about it, actually? Because so many times administration's turning a blind eye, et cetera, et cetera, et cetera. Yeah. And then Jimmy emails me, and he's like, yo, I took your class back in the day. Also, I'm really passionate about this subject and actually have a startup that we do that teaches people how to defend themselves. And I said, okay, don't tell me anymore. I'm going to be in the Bay Area. He is, you work in the Bay Area as an emergency doc.
Yep.
Why don't we hook up and we'll talk about it live? And that's what we're doing.
Yep.
So the goal of this episode is to help you guys understand ways you might be more aware on the front lines, what we can do to train ourselves to be safer at work when we're in potentially hostile situations, and importantly, how to prevent those situations. Right?
You got it. Yep.
So how did you get into all this, man?
Yeah. So one thing I do want to say, though, violence in healthcare is not a new thing. It's been going on for ages, and I think because of social media and just access to news, it's actually being more outspoken now. We can see it now in the media.
So you think it's always been happening?
It's always been happening, yeah. I think. And I think that it's just been more apparent now, and maybe even more now. Yeah. If you look at in medicine, we always talk about, what's the evidence? Show me the evidence and the data behind this, right? So if you look at the evidence behind this, evidence is pretty sparse. But wherever you look at, whether you're talking about the United States, the UK, Canada, Australia, wherever it may be, it's happening all across the globe. Yeah. And it's not being addressed as well. Yeah. It's being under-addressed. It's getting worse, and a lot of us are getting hurt about it because of it. So, what other issue in any other industry is this happening, right? Yeah. Like, it's not like we are dealing with MIs and leaving it alone. Right. We're treating it, and we're taking care of it. And so this has kind of been an ongoing issue, I would argue, that's been escalating over the years, and now we're just hearing more and more about it. And it's also escalating more because of other issues. Well,
I think you nailed what a lot of us are feeling, and when we do these shows, we get so many comments from people. I was hit, I was punched, I was bit, I threw my back out, I've been on disability, I continue to work, and in Australia, it's a huge problem, so much so that they have a whole campaign, right? So I think you nailed it. So but you must have had some history of being interested in self-defense.
Yeah, exactly. I kind of fell into it. I was always a very physical person, competing in wrestling and boxing and whatnot. I fell into Filipino martial arts.
Really?
Yeah. I was training at a Muay Thai gym. This guy said, hey, you want to spar? This guy's like 6'4", 230. And I was 21 at the time. I was like, sure, I'll spar with you. Kick my butt.
Yeah, well, yeah. Oh, wow.
Turns out he was an ex-Marine Corps vet.
Oh, yeah.
Cool. Who was actually trained to be a executive bodyguard for, political figures and whatnot. Wow. And we became good friends. We talked about, and he was studying Filipino martial arts. And he basically led me to this instructor named Robert Castro, who's actually in the Bay Area, and I started learning from him. So I fell into that and started teaching it. So I've been teaching self-defense and martial arts for probably 15, going on 16 years now.
Wow.
And throughout my journeys, my healthcare career, wherever I was in med school in St. Louis, in Missouri, in New York, wherever I went, people kept asking, hey, can you show us a little something for defense? Can you show us how to be safe on the job? So I've taught not only healthcare, but law enforcement, amateur fighters. I've actually coached them and taught them in various venues. Wow. But as my career kind of got more focused on my medical career, people in the ER, clinics, psych facilities say, hey, can you show us a little something, something? And that's how I grew up. So about a year and a half ago, my buddy who owns the part owner of the martial arts school in San Francisco said, hey, let's come together and create something because it sounds like this is a need that needs to be addressed. And so he and I got together and created My Occupational Defense, which is our company.
MyOccupationalDefense.com if you guys are interested in checking it out.
Yeah. And so what's unique about us is basically...
And by the way, they're not paying for this. We're just having a conversation. So you can check it out or not. Yeah. I don't care. If he were paying me, I'd be like, go check it out. But he's not because he's broke.
Check it out. But yeah, so there's a lot of companies that do this. It's a huge industry. I think it's great because they're opening up the door and having conversations. Hey, this is happening. Here's what we offer. I think it's time now to take it to the next step. And what that is applying it in clinical context. I think a lot of the approach from these companies is very militant. Like, hey, block here, do this, do this, do this. I don't think it's beneficial in a clinical scenario. So our group is actually comprised of myself, I'm a ER doc, firefighters, paramedics, first-line people, nurses, who actually came together and created a curriculum for this.
So because, you hear a lot about self-defense, and there's a lot of people teaching, like you said. So the idea that it's different when you're in a clinical situation. How many of us have been through the situation where it's like, don't fight back, de-escalate and run away, or call for help, or whatever. So you have probably a unique spin on this, being a healthcare person as well, and emergency medicine, which is actually the front lines of where a lot of the violence happens, because you get the most agitated people, that drunk in the after the big game at Stanford comes in and is swinging, and
Well, there's a lot to talk about with that. I mean, and so healthcare security, healthcare safety is a huge spectrum, because what's unique about healthcare is not everyone that hurts us means to, right? You can have your developmental delay pediatric patient who just bites. I used to be a kindergarten teacher long years ago, and I had a class of 20 kids, one of which was developmentally delayed, and my longest days was when that kid's aide was not with him. Right? Because he's a biter. But at the same time, I had to understand this. He didn't mean to hurt me at all. That's just kind of his behavior. You have your 88-year-old who's having, a STEMI, or who's septic, or who's delirious from a fever. They scratch, they bite, they pull. So not everyone in the hospital setting means to do us harm.
And like dealing with Tom Heineber, who's on here now, my producer. He'll bite, he'll slap, severe developmental delay. I mean, I'm not talking like mild. I'm talking like institutionalizable. But I've learned to handle him. So the idea in healthcare situations is that, again, you're dealing with a continuum. Some people have volitional anger issues and violence, and some really it's involitional. And that's been a big discussion that we've had, Z-Pack. How do you deal with someone who's demented and agitated? And, it's not like you can hit them back, or it's a very different situation, right, than being on the street and someone attacks you. Right?
Absolutely.
So how then, when you're talking to, say, a nurse, and let's say it's an emergency department nurse, and you're trying to say, well, okay, what can you do to be safer in these environments? I mean, what's your sort of protocol? How do you go through that with them?
Yeah, so that's a great question. So it's actually a step back. So it's actually a three-headed monster. I think a lot of this is basically patient education, for one. Okay, so a lot of patients don't understand that this is happening. This behavior is actually being experienced by us. A lot of my friends who are not in healthcare say, you create a company to do what? That happens to you guys? Just over this weekend, I was working a shift, and I was checking the patient's mandible because she fell. And she's like, I was like, don't bite me, okay? She's like, bite you? That happens to you guys? I'm like, people
all the time.
All the time. And I was joking, obviously. And all my friends who are not in healthcare are surprised that we do.
Wait, you have friends who aren't in healthcare?
I have friends.
How'd you manage that?
I have friends.
Because I have none. Like, all my friends are in healthcare because all my non-healthcare friends went off when I did residency. So they're surprised that this happens.
They are surprised. And so I think we have to have some kind of educational component to this. That's the first thing.
Do you think we're undereducated in
I think
healthcare?
so. I think so.
Seems pretty clear.
Yeah.
I never got any training on de-escalation.
Neither did I.
Yeah.
So I think that's part of the components. The other thing is de-escalation, talking down, obviously. If you're able to redirect a conversation and appease someone psychologically, that's all the better.
Yeah.
So there's certain things we script out that you teach them to guide the conversation elsewhere. And this is where our law enforcement buddies came in. I mean, that's what hostage negotiators do. They have a similar curriculum. We're not creating anything new. We're not reinventing the wheel.
You're just applying it to healthcare.
Exactly. And you talk about stress. What's more stressful than a sick patient coding in front of you, right? Also, just as stressful as a patient attacking you, right? So we have the perfect stress response. Now we just have to apply the stress response to violence in healthcare. right?
So that same increase in heart rate, cortisol surge, adrenaline surge that you get when someone's in asystole all of a sudden in front of you.
Yep.
How do you turn that in the same useful way that you do in a code?
So that's a great question. Right? So I thank my training for that, because I mean, I've been doing this. I've been attending for maybe 7, 8 years now, going on, and I still crap my pants when a sick patient rolls through the door. Right.
I do it too.
And so what saves me is.
But I just crap my pants anyways, because I'm largely incontinent of feces and mostly incontinent of urine as well.
Mostly urine.
Mostly urine, but the feces thing has been an increasing problem. So you still get nervous when when a sick patient comes in. Yeah.
So what saves us, as all providers do? So basically our protocols, right? So once a patient hits the door, ABC, IVO2 monitor, EKG, finger stick. Okay, now I have an automatic protocol reflex that actually gets me into the game. Now I'm starting to think. Now I'm over the flight, the
fight or flight.
Yeah, exactly. So when a stressful situation happens, when someone's attacking you, whether it be a patient or if you're just going home, going to your car, going home, whatever it may be, there's that moment. So we actually created a curriculum where we actually react 1, 2, 3, 1, 2, 3, 1, 2, 3. One thing I've learned over the years as you teach self-defense, and no matter whatever context is, you have to keep it simple. You can't teach a 20-step maneuver. You can't, say, hey, do a crane kick, right? For those of you who remember Karate Kid, it's not
wax on, wax off,
wax off. It's actually a true technique.
Is it?
It is.
Oh.
But you can't apply these things in clinical context, right? So what do you do if you're drawing blood and the patient flips out on you? What do you do when you do an EKG and the patient just get these off me and they rip off the leads and start fighting?
Because that's when it happens.
Yeah. So we actually created sim scenarios for this. And basically we address the situation where, and what's unique about what we do is we do everything in concert. We're not like, hey, here's a slideshow, here's de-escalation, get up now, stretch, balance techniques. No. Everything has to be done in unison. In sim. So we teach people a simple skill set, 1, 2, 3. That's the challenge that I think teaching self-defense in general, you kind of have to acknowledge. You have to teach the new grad who's physically fit, doing CrossFit, how to do techniques, as well as the 65-year-old, almost retired nurse how to do the same techniques.
Which is the one who was stabbed in Massachusetts, right?
And you don't know the mass population. You don't know if I have a bad hip, rotator cuff injury, hardware in my knees, whatever it may be. I may be on Coumadin, right? As a healthcare provider. So you don't know what someone's limitations are, but you have to give them that skill set.
So it's more like a general first principles that people can use regardless. And by the way, I apologize for all the noise. It's a big bamboo tree that's going because we're in the sticks right now up in Portola Valley.
I thought he was going to murder me when I drove up here because I couldn't find the place.
It's true. So literally the reason we pick such a secluded place is that we have stalkers. Most of them are vegans and most of them are crazy. So we come up here and I tell him, here's the address. And he's like, okay. And then I have to go pick my wife up from Stanford and bring her back. So there was nobody here. So he comes out here and it's like Freddy Kruegerville, like Friday the 13th. And he almost walks into a stranger's house down the road where I think they're exorcising demons.
Almost got shot.
Almost got shot. But luckily he has skills. The crane, wax on, wax off. So sorry. So these principles, and again, we haven't seen each other in 25 years or something. So that's a good way to restart a connection, right? Yeah, getting shot. And waxing on and waxing off. I want to take a couple comments while we're talking because I think some interesting stuff must be coming up now. Let's take a look. So I would always try to put myself between the exit and the patient if I could, and if not, make sure I could get a call light or at least a ripcord out of the wall, says Jamie Giblin. Is that a good approach?
Yeah, so that's a great comment, and that's a great segue into the other component. So we're not gonna teach someone a skill set and say you're done.
Yeah.
There's a systemic standpoint too. The system has to be arranged so that we're optimized safe. One of the nurses I used to work with, for example, the EMS were bringing in a drunk, right, on a stretcher.
That never happens.
Right.
Yeah.
In a corner room in the hospital, right? So at the ER, so they wheeled the guy in. They transferred him to the bed, but the nurse was on the other side of the bed in the corner of the room. Patient flips out, right? He was calm initially, right? But then now you have the gurney of the ER barricading the room, the EMS gurney barricading the room, the nurse is trapped in the corner and the patient's in between them. Luckily, nothing happened. She was fine, luckily, knock on wood. But that could be easily fixed very simply from room arrangement.
Yeah.
Some of the other triage rooms basically have the nurse sitting at the computer, the patient's behind them.
Yeah.
They can't see the patient if something were to happen.
How many of us have been in that?
Right?
Yeah.
And again, we're not reinventing the wheel. How do we set up a room for a pelvic exam? The patient is facing the wall, not the door.
Yeah.
So if EVS comes in and cleans the room, not walk into a pelvic exam.
Right.
These are very easy things that preempt any great physical harm.
Right.
Right. And so Setting up a room so that your egress is right in front of you, right? Is the way to go. I used to be a bouncer in a club in SF.
Of course you were.
Way back in the day,
Yeah.
and we set up the club so that if there was a fire or if someone were to pop off, we were able to get the people out safely without having to jump over tables and bar stools and get trampled on.
So it's as simple. It's not simple, but there's a simplicity to systems design that allows you then to in a way, through the environment, de-escalate or pre-escalate. Never let it get to a point where it's a problem.
Yeah.
But so many of us in healthcare, that's not even on the radar.
Yeah.
Especially now with administrations that are kind of incentivized for patient satisfaction.
Yeah.
So the place should feel like a hotel. It should look like a hotel.
Right.
There shouldn't feel like a military barracks. All this stuff.
Yeah.
How do you think around that? Do you think administrators are actually motivated to protect their staff, or?
I think so. I mean, I don't want to label the administrators as bad guys at all.
Because they're usually not, right?
No. I think we're all on the same team in terms of, taking care of patients, taking care of our staff. But it's just that there's so many holes to fill that, and our niche jobs basically pull us away from our attention from different aspects. I'm not an administrator. I love self-defense. I love safety, and this gives me the opportunity to go into this niche and address it when someone's busy. I'm not balancing the budget.
Yeah.
I don't have to worry about quality control.
Right.
I don't have to worry about safety in the
age
sense,
caps.
Right. Exactly.
Yeah.
I don't have to worry about that. So this gives me the ability to have the freedom to focus my attention on this.
Let me ask you a question. So Adam Bailey says, I'm a security officer for my hospital. Anytime there's a violent patient, we're called. We come in and try to talk them down. Majority of those are meth patients or mental health issue.
Yeah.
So at times we go hands-on.
Yeah.
Our hands are tied on some things, and we have to call the police department.
Yeah.
Wish it was different. What's your experience with hospital security?
That is a excellent question.
Yeah.
So right now we're in works with a hospital up in the Northwest to create a curriculum for hospital personnel safety of the security staff in the hospital specifically.
Right.
The challenge for that is, so we've all seen a cluster where a patient goes wild.
Yeah.
It's a dog pile. Nurses jump on, docs jump on, techs jump on.
Yeah.
Security jumps on. That's where the opportunity for harm happens.
Right.
And one thing I do want to mention is why this is so important is because one thing that's we're exposed to is body fluids, right? The sharps and needles. I've had 3 needle sticks in my career.
Good Lord.
I was on PEP for the second one, and I lost like 20 pounds in like a month.
PEP is post-exposure prophylaxis for those who don't know, and it's high dose or particular dosed antiretrovirals.
Right.
Yeah.
And,
so you lost a bunch of weight.
I lost 15 to 20 pounds in about a
Dude,
month.
I want to go on that.
I was ripped.
Yeah,
It was awesome.
Say, okay, guys, go out there right now and take post-exposure prophylaxis for HIV, and you'll just.
I was ripped, and I was on nights, so I didn't eat, I didn't sleep. I was ripped.
That's terrible, actually.
But in all seriousness, that's an element of harm that I think gets underaddressed as well. So if you get stuck with needle, guess what? If I'm trying to raise a family with my wife, I can't do it. And that affects our life together.
You literally can't do it.
Yeah.
Because there's going to be a period where you're going to have to wait to get tested.
Right, because I don't want to affect my wife.
And look, how many of us have got needle sticks?
Yeah.
I mean, it is terrifying.
Yeah.
It is terrifying.
Your life literally does flash across your eyes.
It does. And it should, because your life is in danger.
Yeah.
Right, yeah.
So I think that's why there should be more emphasis on hospital safety.
Yeah.
But yeah, anyways, back to the topic at hand in terms of how do hospital security do this. So there has to be a collaborative effect in terms of integrating security with the staff. Everyone has to know their role. Like when a bad trauma comes in, it's a beautiful thing in a sense because everybody in the team knows what to do, right? The patient gets on the gurney, IVs are put in, someone's getting EKG, someone's got the chest tube tray if they need it, someone's got the airway. There's 2 docs sometimes in there. Everyone kind of swarms, and in a very with a very experienced staff, it looks very orchestrated.
Yeah, like a code.
Yeah.
Like a well-run code. Let's be careful about, because some codes are just shitstorms.
Exactly.
Yeah.
And sometimes can't be avoided because whenever that you don't know what's going on, patient's super sick.
Right. Families there.
Families
in the room.
Yeah.
Right. Yeah.
And so I think that we need to kind of integrate that same team approach when it comes to security in the hospital.
Do you think, now, here's a comment from Aaron. I work at Santa Clara Valley Medical, where I trained there partially for our county hospital. Our patient population has become increasingly violent. We have an extremely hard time keeping nurses. 85% of new nurses are leaving within the first 12 months.
That sucks.
Yeah.
And I experienced this personally because one of the hospitals I work at, we've lost a lot of nurses because of burnout. I mean, not just because of violence, but because of
a bunch
burnout.
of different things, yeah.
But I think violence contributed to it. And
Yeah.
these nurses are amazing. Like,
Yeah.
we go hang out together after work, and if I were to build an ER from the ground up, I would have pulled these nurses.
Hire these nurses.
just
So we're
start
losing
off.
great people.
Yeah, it's not like,
Right.
and it's not like they've been in their career for 25 years.
Yeah.
They're fresh,
Yeah.
energetic, highly skilled, highly intelligent people,
Yeah.
and very compassionate, and they want to help people.
Yeah.
But it hurts and it's sad to see people, and docs also, and
Yeah.
techs, and everybody,
yeah.
all the roles in the healthcare.
I mean, and that's a multifactorial thing we talk about a lot,
Yeah.
CPAC, you know, whether it's EHR and
Yeah.
having to click the boxes, whether it's having to appease patient satisfaction to the extent that it impedes actual patient care. Like, imagine running a code
Yeah.
and you're worried about what the family is going to do on their survey.
Mhm.
You're going to run that code in a way that's not necessarily beneficial to the patient.
Exactly.
Because a real code is ugly and messy, and sometimes you
Yeah.
actually want the family there to see that.
Yeah.
Right.
Yeah.
Now, have you had situations where patient members get violent during a serious procedure or code, and how do you deal with that?
Yeah, so they do. So
It's usually family we're talking
yeah,
about.
I think the best example is, you have a patient who comes in for a GSW who's shot in the chest,
Yeah.
and then you
Gunshot
have
wound. Yeah.
and then you have the family or friend who's super angry. It's like, if something happens to him, something happens to you, that kind of escalation.
Mhm.
I
Yeah, we hear that all the time. If
Yeah.
if he dies, you better watch out.
Yeah.
Yeah.
And I've personally been threatened like that before.
Sure.
And so it's unnerving, and especially when I'm trying to leave my shift and walk in my car by myself.
Right.
I'm looking around, just be
Right.
careful.
Right.
So I think we need a mediator for that. We need someone else who's not involved in the code. We need someone to basically guide the family friend through the process.
Mm.
Also, similarly, in a violent situation, again, what I said earlier about not everybody that lashes out means it's harm. So you can have a delirious 85-year-old who's just scratching, clawing, biting, and then the family member is like, "What are you doing to grandma? What are you doing to grandma?"
Exactly. And Melanie Thompson points that out,
Yeah.
the big difference between mentally disabled behavior dementia patient and aggressive family member.
Yeah.
So go ahead.
Yeah, and so I think, and this is a resource allocation issue, obviously.
Yeah.
We can't have, someone dedicated for that, but we should.
Yeah.
But you need someone to explain to the family friend, whoever is with the patient, say, hey, they're really sick right now. We're doing the best we can. We're just gonna calm them down, and then we're gonna take care of them afterwards. Okay, you might not want to see this. If you do, that's fine. We'll take your hand and walk you through it.
Yeah.
And so I think that level of empathy with the family is helpful.
Yeah.
And because a lot of what happens to healthcare, a lot of frustration is not knowing.
Yeah.
A lot of my friends have asked me to be by their side when their loved one is in the hospital, because just to explain to them what's going on. And explain to them, and having knowledge is kind of half the battle, like G.I. Joe says.
G.I. Joe.
Right? Knowing is half the battle. So I think...
Children of the 80s.
Yeah.
Yeah.
And I think that's probably super helpful to have a advocate, not to advocate for you, but to explain things for you.
Yeah.
So I think that's probably part of the process. So to answer the question, multifactorial, you have to deal with educating the patients. You have to have your facilities already in place to facilitate safety, right? Arranging a room so you don't get trampled on, you're not barricaded in the room. And grounds to boots. You have to give your staff a skill set in case things pop off.
And support them if things do pop off.
Yeah.
So
yeah.
some of the questions, some of the comments we've gotten are like, well, okay, now I've been hit, I've been assaulted.
Yeah.
How do I get the appropriate support?
Yeah.
There's PTSD.
Yep.
There's legal stuff. So like, if I want to press charges, how come they never follow through?
I'm glad you said that,
Yeah.
because the average person on the street has more legal protection than we do in the hospital.
Motherfucker.
Right.
So, this is the thing, right? That
Right.
gets me so angry.
Yeah.
Because we all know this. Like, if I go and punch my mechanic, I'm going to jail, right? And he's going to kick my ass because he's big and Turkish. But if I come into your ER and I'm like, fuck you, you didn't give me my Dilaudid, and I start hitting you, it's going to probably be swept away.
Right, exactly.
So tell me about what you think about it.
Yeah, so, honestly, if I were to start my shift, put my MD badge on, and get hit in the face, everything gets under the rug, right? So
Yeah.
if I were to take off the badge, put on my street clothes, and walk down the street, guess what? That guy's going to jail.
Yeah.
Right? If I don't hit back and run away or whatever.
Right.
So that's a discrepancy that I think legally
Has to be closed.
has to be on a higher level, and it's on a level greater than what I can manage.
Right.
But what I'm hoping is to change the culture, because, the culture of healthcare, and you've said it before with Silent No More, is it's okay. Right?
Yeah.
Like, it's kind of
It's part of the job.
It's part of our job.
You signed up for this.
Right.
Yeah.
It's our red badge of courage.
Right.
Right. It's like, okay, it's expected. Like a few months ago, a few of my coworkers got punched and scratched, and I mean, are you okay? It's like, yeah, I'm fine. You need to go HR? No, I'm good. I'm like, well,
suck it up culture.
Right.
Yeah.
And we kind of take pride in that because we're tough.
Yeah.
We're emergency staff, we're medical staff,
Right.
right? And when we signed up for this, we kind of expected that in a way.
Right.
But I think that's kind of snowballed to such a degree that now we've become numb to it and not addressing it. Now that's become a real problem.
Yeah.
Right?
And I think that goes hand in hand with an increase in violence that comes with sort of closing mental institutions, poor mental health, increasing drug use, particularly opioids.
Yeah.
So all of this colludes to make us now in a position where this is no longer something we can tolerate.
Absolutely.
Which is why, Silent No More, the whole movement that we have, Z-Pack, is so important. And I was so excited to have Jimmy on the show because even though we hadn't talked about this, I got a sense, even through the email, that he was passionate about this, and it's clear from what he's saying that he is. So we need more people, I think, who hit that nexus of healthcare person and defense expert and reasonably compassionate dude to actually help us understand.
Yeah, and by no means what our company or what I do is going to be the end all be all. It's not going to be a total answer.
Right.
But kind of like what you're doing is we basically want to start the conversation.
Yeah.
And here are some potential solutions to make things better. Here are some things that we can do right now to basically be safe. And again, it's going to be a multifactorial approach. We need help from the top down from the administrators.
Yeah.
Bottom up from patients to realize, hey, this is happening. Governmentally, legally, statewide, federal-wide, we need more laws to support us.
Do you think those signs that some administrations are putting up that say it is a zero-tolerance offense, a felony to assault a healthcare worker while on this premises, do you think they help?
Yes, they do, but I think that there's even more to that.
Yeah.
I think it has to be approached from a marketing standpoint.
Yeah.
So, and you basically look at all these companies like Google, Apple, and everything's nice and pretty, and they bring their point across, but it's all wrapped in a nice shiny wrapper.
Yeah. We don't have that.
We don't have any wrapper, right?
Yeah. We have a wrapper.
We have a wrapper.
But let's put that in quotes. I'm an off-white wrapper.
Right.
Yeah.
But I think to say zero tolerance, nothing will be tolerated here, you will get kicked out, is probably adversarial.
Yeah.
I think that message needs to be brought across, but maybe in a softer message.
I see. Yeah.
Maybe in a marketing sign that says, this many nurses get assaulted every day. Please don't be part of the problem.
Oh, yeah. That's interesting. So a less adversarial, because it does kind of generate a certain us and them mentality.
Yeah, and that's not what we want to cultivate. We want
Right.
to we went to healthcare to take care of patients, not to bully patients.
Right. So like a sign that shows a jail cell with some flowers in the toilet and be like, jail is great this time of year. You want to try it? Just come at me, bro. Is probably not. Maybe somewhere in between.
That's
not bad.
I'm not
right?
opposed to it.
That's not bad.
That's not bad.
You got to admit.
That's not bad.
Should we take some comments together?
Yeah, let's do it.
Yeah. All right. Let's see what we got now. I haven't screened any of these, so we'll just read them out. A lot different now. Their grandsons may come in with a gun because grandma said you didn't bring her meds on time. Vicky Miguez. So, it's again, like, I think patient expectations have gotten crazy.
Yeah.
Like, this is a hotel, not a hospital. The largest issue is that intentional violence against a healthcare worker needs to be listed as a felony, charged nationwide, and more healthcare workers need to be willing to go forth with the charges, not allowing hospitals to decide. Jeremy Lemaster.
Yeah, I think that's a great point, because I think we need to kind of set precedents, which is huge.
Yeah. And I agree. It doesn't necessarily have to be adversarial.
No, not at all.
It just has to be a cultural thing. It's not okay to do this. They had to have a series of really moving videos in Australia because Australian EMS was being attacked constantly. And the videos were well done because they really move you to compassion for the caregivers.
Yeah, I'm glad you brought up EMS because we actually started a program with SF Fire, actually.
Oh, really?
Yeah, I did a session for them a few months ago.
Those guys are hunks. I'm just saying. I'm not gay, but if I were, it would be an SF fireman because hunks. Anyways, please continue.
Oh, yeah. So they pick up drunk and battered patients all the time. So we ran a session for them in simulating a rig, simulating stretcher. So EMS is something that we forgot to mention in terms of frontline people that deal with this all the time.
How many times have you been forgotten EMS? Word. We don't forget you. So is there a particular difference in the training you would give a guy in a rig who's going into a demilitarized zone versus a nurse in an emergency department, or is it the same principle?
Yeah, that's great. So we basically distilled our skill set into a very simple 1, 2, 3 applicable skill set. Like I said, unless you keep it simple, it's hard to execute. And it took me, I don't know how many years to learn how to intubate a patient.
Yeah.
Put in a breathing tube.
Yeah.
I still miss sometimes and flail.
That's because you're an emergency doc. You can't.
I still see patients at least. Sorry.
I see patients too, just only a few times a month at our county hospital with residents.
But you know, if I can learn a basic skill like lift, look, push in a tube.
Yeah.
You know, 1, 2, 3, learning to evade and attack is not that difficult, to be honest. So,
Now, how can people learn more about your thing? Go to the website.
go to our website, check us out.
And we'll put the link up there, myoccupationaldefense.com. But there are other groups that are doing this. Many of them have reached out to me. Find something that fits you.
Yeah, absolutely. And we also have a non-medical arm as well, self-defense for the people. You guys check that out if you want. I'll send Zubin the link.
Perfect.
So you can take a look at that.
Yeah, we'll share that with you guys. Let's see. Very different in long-term care, older age communities. Violence goes on there, but what will laws do against individuals in their 90s who abuse staff? So, Shaughnessy Fournier, I guess a question I would have is, well, should we ever get to that point, or should it be more about avoidance, de-escalation, and management of behavior as opposed to responding when someone does hit you?
Yeah, so that's actually great. So our what we teach our staff actually is a whole spectrum. You don't have to go all out Rambo on somebody.
Oh, but come on, beating up a 90-year-old is like high on my list of things to do, right?
You know, the 90-year-old that's scratching you, who's in bed because she didn't get her meds, is different than the 35-year-old meth head who's swinging at you. So the beauty of our skill set is the fact that you can actually apply the same 1, 2, 3 skill without having to escalate.
Yeah.
So it's hard to describe without actually seeing it in action. So,
Right.
But yeah.
And Aaron Fourquer throws in the little punch. Jaco never asks about staff safety. Staff safety equals patient safety. Do you agree with that?
So
Joint Commission and our
they need to ask
regulatory-
about staff safety.
Yeah. In fact, I would say that hospitals should get paid partially based on staff safety and staff satisfaction. Do we feel connected and supported?
Right.
Part of a higher purpose. Right?
I don't know how it is at other institutions, but when we hear the letters JACO or whatever the acronym is these days.
Yeah, it's not Jaco. They get
Like-
mad when I call him Jaco. I'm like, you haven't deserved not being called Jaco.
Right. I hide my coffee. I hide my food, right? Hey, they're here, right?
That's right.
And so this is...
The badge goes up to the nipple instead of down in the crotch where it was.
Exactly.
Right. Yeah,
exactly. That fear shouldn't exist.
Yeah.
We should feel like they're working in partnership with us.
Yeah,
Hey,
yeah.
how are the patients doing? Hey, how are you guys doing
Yeah,
as physicians or as nurses or as techs?
We ought to be like this. Oh my gosh, Jaco's coming.
Yeah.
Let's tell him all about all the great stuff and some of the challenges we're having, and then let's figure out how to make it better.
Right.
But that's a ways away.
Exactly.
But it shouldn't be a problem.
No, but what's great is that now we're starting the conversation. Right?
Yeah,
We're
yeah.
starting to address these issues that no one knew about, no one talked about.
Yeah.
Non-medical people don't know about it. Now it's time for the politicians to hear about it.
Yeah.
Right? Now that we're speaking about it.
Yeah.
Now it's time for our patients to hear about it too.
Yeah.
And I think that's a huge first step in addition to everything else we're doing.
Yeah.
So-
No, that's fantastic.
Yeah.
So tell me, man, in sort of summary, what are you apart from the self-defense piece and the occupational defense, what are you crazy passionate about these days? What are you up to?
That's actually it. Actually, I work out a lot. I try to stay healthy. I'm getting older. So
I like to tell people that I do that and then not do it.
I like to eat. I'm a huge foodie.
Are you? Yeah, me too.
Yeah, so I go out to eat whenever I can.
Yeah. Are you up in the city?
I am.
San Francisco.
Yeah,
Yeah.
yeah.
Great food up there. Yeah.
Let's see, and the company teaching self-defense. I teach also outside the company, private lessons and self-defense and all that stuff.
Awesome.
Now
Now we'll get personal because it's our show. Are you single or married?
I am single.
Jim's Choice, single ladies, hit him up. So, Jimmy, if you are actually going through the comments later as your company, are you okay with answering people's questions?
Yeah, absolutely. If you guys have any questions, feedback, critiques, comments, questions, please shoot them our way.
Put them in the comments.
Yeah, we'll try to address them and answer them. Obviously. Yeah.
Perfect. So, guys, Silent No More. We're talking about this stuff. We want actual actionable interventions that we can make to keep people safe in the hospital, and I think this conversation is a start. It's not the end of it.
No.
And maybe hopefully in the future we can get Jimmy back on when he's in Vegas in our real studio and have a more in-depth conversation, maybe even some demonstrations where Tom tries to come at him and he just punches his lights out, which would be amazing. Actually, that's probably not what you do, but
I'll take out my knife.
Even better. and I'll be like, that's not a knife. This is a knife, and I'll bring out like a butter knife that's like crappy. Guys, it's been real. Jimmy, thanks for being on the show, man.
Thanks for having me.
It's legit, and I'm sorry you failed the MCAT twice, but that was not my
I
fault.
took it twice. I didn't fail it twice.
Okay, well, I failed it 3 times and then passed on the dirt. All right, guys, we love you. We out. Peace. Hit
Thanks, guys.
share. Hit like if you like interviews, man. Recommend people we should interview, because when we get back to Vegas, it's going to be on like Diddy Kong, because Donkey Kong's a punk. You know what I'm saying?